Hi, it's Dr. Centeno. Sorry I'm a little bit late here. Just having some lighting issues. You can kind of see the flickering there. I was just trying to get rid of that. Anyway, long story short is welcome to You've Got the Power. And today we're going to have a really interesting topic on blurry vision, and can that be in any way related to your neck? Now, obviously, there are lots of people with all sorts of eye problems that have nothing to do with their neck. But our focus today are those situations where the neck is causing blurry vision. So let's go ahead and start the presentation. Again, it's going to be the neck and blurry vision. And then in addition to that, you can ask questions after that about that topic or really any topic at all. So let me go ahead and share my screen here. And we'll start the presentation, which is, again, can your neck cause blurry vision? So let's go ahead and start that. So we'll start out this topic again, after which we'll go to questions. You can ask questions about this or anything you would like. So can your neck be involved in or cause blurry vision? Again, and I'll say it a few times during this presentation, lots of things cause blurry vision. And so obviously you need to see a qualified ophthalmologist to see what's going on. But if they don't come up with anything and you've got upper neck issues, then it could be your neck. And again, one of the things that we've been noticing is that CCI patients need a lot of extra specialized attention in order to get to that point where they can get to a telemedicine visit. And we've got a great call center, but our call center deals with everything from ankles to low backs to wrists to knees. And this is such a specialized area. I would recommend that if you're interested in getting evaluated, to go ahead and contact Carla, and her email address is right there. She's my assistant and she handles all of the CCI referrals in our clinic, and she can get you into the right system much more quickly than if you try to go through the call center, where it may be more difficult because, you know, they're handling everything, whereas Carla just does CCI. So these are the references for today's presentation, and we'll be focusing again on two main causes of cervical dizziness. So if you look at craniocervical instability symptoms, you see that, you know, the size of all of these things is directly related to how often those complaints are there. So obviously the big ones would be headache and dizziness, lightheadedness. And then the next level down, you get to numbness and tingling and neck pain. Then the next level down, you get into brain fog. But the next level down, or in a similar level to brain fog, is blurry vision. So it's there and not uncommonly. So we're going to go over two neck-related reasons for blurry vision. One is what's called the cervical ocular reflex, the concept that your neck and your eyes are very much linked. And the other is the superior cervical sympathetic ganglion. So we'll talk about both of those today. So the cervical ocular reflex. So basically, the position sense information from your upper neck is coordinated with your eyes. And you might ask yourself, well, why would that be? Well, if you think about it from a primitive standpoint, let's say we're going to throw a spear at an animal. That animal is going to come across our visual field. Now, we're going to have to turn our head to scan where that animal is. And if we're going to throw a spear to hit it, we're going to be able to, or we're going to need to be able to coordinate that input coming in from the neck with our eyes to accurately track that target. And that tracking something as it comes across your visual field is called a smooth pursuit. Now, there is a test that can be done to measure the efficiency of that connection, and that's called a smooth pursuit neck torsion test. And that's done as part of a VNG or ENG test for the inner ear. Regrettably, 99.9% of the time, it's done by an ear, nose, and throat doctor who doesn't really get it done that way. And it's not that hard to do. You just do the same smooth pursuit test they normally do as part of an ENG, but you turn the patient's head and repeat it, and you're looking for changes in what's called gain. It just doesn't happen. So this kind of goes like that. The test is done, but the information isn't obtained about the cervical ocular reflex. So again, we're talking about bad input from the upper neck causing problems in the eyes. So diagrammatically, this is what it looks like. Now, this is oversimplified here, but basically there's two reflexes here. One is the information coming in from the upper neck, which then goes through different nuclei and parts of the brain, etc., to get into adjusting your eyes and the position of your eyes. And that is also linked in to the vestibular ocular reflex, cervical ocular reflex, vestibular ocular reflex, and that takes into account your semicircular canals in the inner ear. So your inner ear is linked into what's happening with your neck, and all of this has got to be working perfectly for your eyes to track well. And if for some reason there's a problem up here, and we're getting bad information that's coming along the cervical ocular reflex, it's going to impact what your eyes are doing. So we talked about that smooth pursuit, right? So here we have a person who's looking this direction. So they're stimulating the upper part of their neck, and they're trying to track this little guy down here. And as this little guy comes across the visual field, your eyes obviously move as they start tracking that little guy. And all of that has to be in coordination with your neck, because you're turning your neck at the same time as you may or may not be turning your eyes, depending on what you're looking at. So all of that is coordinated. Now, let's look at what happens when we've got bad information from the upper neck. So now we've got bad information coming from here. The eyes aren't getting that good information about how to coordinate with what's happening with the neck. So one eye is kind of, here, and the other eye is going up that way. And so we see the duck here as blurry. And then when our eyes are tracking better, like down here, we see the duck is not blurry. And then when we turn our neck again, and we've got, again, bad information coming from the upper neck going to the eyes, again, our eyes are all over the place and the duck is blurry again. So what do people notice when they have this issue? One of the things I hear a lot is they really don't like, for instance, walking down a grocery store aisle. Because what do you do when you walk down a grocery store aisle? You're constantly looking like this. Your eyes are looking all over the place. You're looking at all the different things. And that really messes them up. That can cause dizziness sometimes. That can cause visual disturbances. All of those things. In addition, reading can become difficult because we do this kind of thing when we read. We may not move our head as much, but we're moving our eyes. So that's one way that you can get blurry or disturbed vision, through your upper neck, through the lack of good information coming in from that high upper neck as it connects to the cervical ocular reflex to your eyes. Now, another is through the superior cervical sympathetic ganglion. Now, I have to say, I've known about the first one we talked about for almost 2 decades. This one is interesting because I had a patient who had one eye blown, one pupil blown, and it seemed to be related to what was going on in the neck. So this was an interesting deep dive to do into why that would happen. And this was a craniocervical instability patient. So this little ganglion is part of the sympathetic chain. It's called the superior cervical sympathetic ganglion. So the sympathetic chain would come down this way, and then it goes up that way. Now, the sympathetic chain is part and parcel of the sympathetic nervous system. And the sympathetic nervous system is linked into lots of different things. It's linked into activating the fight or flight response. It's linked into vision as well, in that all of this hooks up into the optic nerve to help control your pupils. And it's part of that thing because if you think about activating the sympathetic nervous system, again, that's that fight or flight. So if we activate that, what's going to happen? Well, one of the things we're going to want to do is to take in as much information as we possibly can. So we want to open our pupil because we think something's going to come get us, and we'd like to see what that is. So that's part of that sympathetic response. So you've got this connection between the superior cervical sympathetic ganglion, which, guess what, happens to live right in front of C1 and C2 here. You know, if you've got craniocervical instability or upper cervical problems, that's going to mean something to you, right? If you've got C1, C2 issues, this can get irritated. And it goes directly into the size of the pupil. So I've heard CCI patients now describe that they notice that they may have one pupil that gets bigger or smaller depending on what's going on in their neck. So if we irritate this area or activate it, that's going to cause, like I said, the pupil to get wider, because that's the activation of the sympathetic nervous system. And we think something's attacking us. And so you want the pupils wider to get as much light in as possible into that eye, because you want to see whatever it is that might be coming at you. Now, again, if there's irritation right in front of C1, C2 here, you can get this type of blown pupil. It's called a reverse Horner syndrome, or this Porphyre du Petit syndrome, either name. Now, if we go the other direction and this were to get completely damaged, or we inject some anesthetic here, that goes the other direction. Now we've got a tiny pupil. So for instance, if someone gets a stellate ganglion block, which is down in here, which is part of that sympathetic chain, then you see this meiosis where the pupil goes really, really small. So irritation blows the pupil, damage constricts the pupil. Now, how could that impact vision? Well, we know it does. This is actually really old stuff. It's an old paper from the 1950s, but what they're showing here is that the diameter of the pupil dramatically affects visual acuity. And we also know this is true because of this product. This product just came on the market. Now, this was really pumped about a year ago in the media by the company that makes this, which is Allergan, a big drug company. The idea here is you can get rid of these things. You can get rid of your reading glasses if you go ahead and put these eye drops in. Now, how does that work? What happens is these eye drops constrict the pupil, and that actually allows you to see close up much better. It also goes the other way, right? It also reduces your ability to see in the distance at night. So you don't want to drive after putting these things in, but if you're just around the house and you don't want to wear glasses, you can put these eye drops in. Again, linking the size of the pupil to visual acuity, meaning your ability to see sharp or blurry. So in conclusion, the neck is involved in how your eyes work. We do see CCI patients with blurry vision. Obviously, all of these patients need to get checked out by the true eye experts in ophthalmology to rule out other diagnoses. But if there are no answers coming back from ophthalmology, your neck could be the cause. So let me go, and I'll stop sharing now, and we'll go to some questions. Looks like we got a bunch of questions here. So let me start here with Andy. Can weakness in the deep neck flexors cause suboccipital muscles to tighten up to compensate for the weakness? Andy, good question. So deep neck flexors, we're talking about the muscles deep in here, the longest colli and longest capitis, and they live just superficial to that anterior longitudinal ligament. Now, what do? When we bring our head back, they can help control the amount of curvature that we're getting. Now, it's been theorized that if those ligaments are in spasm, then we get lack of curvature. And if they're working correctly, they can help increase the curvature or allow it to happen as we bend the head back. Now, they're the anterior stabilizers, and those suboccipital muscles are the posterior stabilizers. So the answer is they should go hand in hand. So if you've got a problem in one, then it can certainly cause a problem in the other. Andy, is it true that the medial portion of the PAOM is sacrificed sometimes during decompression, duroplasty surgeries, because it provides very little stability? It's sacrificed in those decompression surgeries because it's in the way. I mean, that's the reality. It's not because it provides very little stability. It's just because it's in the way. And same thing with the occipital nerve. The occipital nerve is frequently sacrificed in upper cervical C1, C2 fusions, not because you don't need an occipital nerve or not because sacrificing it might not cause chronic headaches, but because it's in the way. And that's the reality of surgery, right? Surgery is always damage to try to accomplish a goal. We hope that the goal we accomplish is better than the damage we did. But obviously, as you're bringing up, if you're going to decompress the back of the skull, you're going to sacrifice the PAOM ligament, which is that ligament deep right up top here in the back. Let's see, who should I contact about making a telemedicine for an evaluation? That would be Carla. As I put in there, but I'll put her email address here. Okay, so I just put her email address in the comments there. She'd be the person to contact. John, can CCI cause peripheral neuropathy? Not really peripheral neuropathy in the strictest sense. But it can certainly cause nerve issues. So for instance, a lot of CCI patients will develop numbness and tingling in their hands, sometimes due to tightness in the scalenes here, and the nerves that go to the hands go through the thoracic outlet and the scalenes down to the hand. Also through other mechanisms as well. So not peripheral neuropathy, but nerve problems in hands or feet. Yes, we see that, or nerve symptoms. It's been advanced by Anne Marie. Ha ha ha, it's not just the vision. The words beyond being blurry and bouncing become scrambled, and the intake to the brain, memory processing, recall are all affected. The eyes are unhappy due to the neck. Your work should have brought out a deep sense of calm that was being compromised by eyes working overtime. Thank you, Anne Marie. So yeah, what you're describing is kind of what I was trying to show there in that one slide. And that is that the eyes start getting out of sync. And I think what you're describing is a phenomenon called nystagmus. So what nystagmus means is that the eyes are jumping around on their own. And since they're jumping around on their own, things are going to get jumbled going into the brain. Now realize that vision and memory are linked. Vision is involved in memory encoding. So what that means, and I've blogged on this before. Let's see if I can find that blog for you. I'm just trying to see if I can find a blog I wrote on memory coding and how it's linked into vision. Here it is here. So if you go to my blog on the regenix.com website, this is some research on how eye movement is involved in encoding memory. And speaking of the jumping, you may see the thing jumping there. It seems like every time I go into this mode, now I'm getting jumping happening in the image. So maybe that's replicating what you guys are experiencing. But bottom line is, this is the blog. And what it means is that you need, when you remember something, that memory is encoded based on what your eyes were doing at the time. So if you don't have a good connection to your eyes and your neck, and your eyes are jumping all over the place, that's going to mess with memory encoding. And this is some relatively new research. We've known something like this for a while, but we're starting to now get some good research on how it works. And again, if you were to see a car crash and looked left to see the car crash, when you remember that car crash, your eyes involuntarily go to the left. Again, linking eye movement and memory encoding. Melissa, is it possible to see improvements on DMX from just cervical PRP treatments, C1 to C7? How many PRP treatments reasonable to get before getting in DMX, new DMX? Generally not. Now, it depends on what it is we're talking about. Let me back up a little bit there. So what we're talking about is something like C2 moving forward on C3. The answer is yes. If what we're talking about is axial instability or side-to-side motion, like C1, C2 overhang related to the alar ligament, the answer is not really. Unlikely that we're going to see improvements from just posterior PRP. There we're going to have to treat the alar ligaments directly through that PICL procedure. Regenix, minute advance by Ben Moses. How can slipping rib syndrome affect heart rate? It probably doesn't impact heart rate directly. What you may have is an upper neck problem irritating the vagus nerve, causing an issue with heart rate, but slipping rib syndrome a little bit less so. Sheila Clonin, does convergence insufficiency and blurry vision following concussion necessarily mean neck involvement, or could there be a different mechanism at play? You know, there certainly could be a different mechanism at play, but what we definitely see is a lot of patients with post-concussion syndrome have had an injury to the upper neck and it hasn't gone diagnosed because the doctors they're seeing don't understand upper neck injury. So they may be completely unrelated, but we see a lot of people with brain injuries. They got a brain injury because they got hit on their head. And when you get hit on your head, the head bone's connected to the neck bone right here. And there can be an upper neck injury as well. So it could be separate, or it could be related and yet undiagnosed. It's been advanced by Beth McCoy. Is EMTT magnetolith deeper and possibly more effective for healing ligaments than shockwave therapy? Is it safe to use for CCI patients so close to the brain? Yeah, so guys, I think we've talked about shockwave and these types of treatments. The goal would be for shockwave at least, would be to try to cause some local irritation, and that would cause a brief inflammatory healing response. Now, the ligaments that we're discussing, if we're trying to treat the ligaments back here, shockwave may get it done. It's going to take a lot of treatments, but it may get it done. But if we're talking about these internal ligaments, no, they're not going to be reached by shockwave. They're not going to be reached by any of these EM technologies because they're surrounded by bone. And there's no way to get to them outside of injection. So it's very unlikely that we're going to see any type of procedure like that impact those deep ligaments that we've been talking about. And even for the posterior ligaments, it's going to take a lot of treatments to try to help those. And we're probably only going to be treating the most superficial layers of those rather than the whole ligament. So for instance, we might be treating the superficial layers of the supraspinous or nuchal ligament, but there are also deep layers of those superficial ligaments, and then even deeper layers in the interspinous ligament, which we're not going to be getting to with those technologies. Melissa, hello, Centeno. How many posterior PRP treatments is it reasonable to try before moving to a PICL? Yeah, Melissa, a lot depends on your response, right? So if you get, for instance, let's say you did the first posterior PRP, you're 40% better, and you hold on to that over a couple of months, then it certainly makes sense to try a second without going to PICL. Let's say the 40% is only transitory. 3 weeks, you feel 40% better, you go right back to where you were. Now we're in PICL territory. Or you do a posterior treatment, no real impact at all. So again, now we're in that PICL territory. So I hope that helps. If you had patients with blurry vision resolve after a successful PICL, yes, we do have patients that report blurry vision and that goes away. And at the same time, one of the more recent things was a patient who I believe has a superior cervical sympathetic ganglion issue. And that tends to go up and down depending on what's going on up here. John, how many dextrose prolotherapy treatments does it take to heal a moderate, loose, lax MCL? The good news is, John, that MCLs are pretty easy to heal. So with an ultrasound-guided prolotherapy injection, usually 1 or 2 should get it done for that kind of issue in the knee. Fetchen, in the study with 95% success in diagnosing CCI with DMX, why the other 5% of people have 4 mm overhang but not CCI? What other diagnosis could they have? So Fetchen, one of the things to realize is that the way we're talking right here and the way you've put it very succinctly is that all imaging findings have a likelihood of being associated with symptoms. And there's very few imaging findings outside of seeing a fracture, for example, that have 100% correlation. In fact, some of them are really badly correlated. So for example, let's say a patient walks in who has never had a day of neck pain. If we take 100 of those patients who are 50 years old and we do MRIs of their neck. Now, we're not doing the MRIs for neck pain. We're just doing a research study. About 60% or 60 of the 100 will have lots of things going on the MRI of the neck, but no symptoms. Same thing. So therefore, we know that that particular finding, let's say it's a disc bulge at C5-6, is by itself not very important, meaning lots of people have it, only some people have symptoms. So we got to be very, very careful with that. And we would report that there's a, now not 5%, but 60% chance that 5-6 disc bulge means nothing. Now for CCI, what we're seeing here is symptomatic CCI versus not. So there could certainly be patients who have instability, but have no symptoms and maybe never will get any symptoms. And that's that 5%. And this is why I always say that some of the neurosurgical stuff I'm less impressed with. So Grab Oaks and CXA and BDI and BAI, all of those measurements have not been subjected to this type of scientific discussion that we're having right now. Meaning, let's take 100 people who have never had any neck issues, measure their BAIs, and see how accurate we are in finding people who have symptoms, which is what this Katz and Freeman study did that you're referencing. So it's an incredibly important concept to keep in mind, that just because you have something on an image doesn't mean it's causing your symptoms. And we want research like this done by Katz and Freeman that allows us to say what the likelihood is that we are wrong when we say that that finding is causing symptoms. Now, 95% is really good, because you got to realize some of these things we talked about, like disc bulges in the neck, are 40% likely to be causing symptoms, not 95. Tony, Centeno, my first PICL 2 weeks ago. Is your omega fish oil product a good supplement to take for inflammation related to vagus nerve dysfunction? Yeah, Tony, that would be a good one to take. Yes. It's been advanced by Sherry. Does treating the CCI fix the blurry vision, or is it something that damages the eyes? Went on for a long time. Again, if it's that superior cervical synthetic ganglion, then if that were damaged, then the eye pupil would go small. So that's how you'd know that you're into the damage category instead of just getting bigger. When it comes to the cervical ocular reflex, that usually gets better when the input from the upper neck is normalized. I can't say I've seen one of those continue to be a problem, although it's not, it's not impossible at all. It's been advanced by Harry Winston. For flying back to England after a PICL procedure in business class necessary so you can lie down. Yeah, probably be a good idea. Especially if lying helps you with your symptoms. If you weren't lying down, then you may want to get one of those sort of neck pillow things so that your head doesn't do this when you go to sleep. John, how can I tell that I flex my neck far enough for an upright MRI? I think best you can do is to do the best you can do. Now, we do medicate people. So sometimes we'll give them Valium prior, they'll have to have a driver, but we'll give them Valium prior to a DMX or a cervical or upright MRI. So if you can't get much flexion or extension, then the next best thing is to get some medications, take those before that. Obviously, you want to make sure you don't hurt yourself, but that's generally the way to do that kind of thing, to try to get a little bit more flexion or extension. How much is needed? As much as you can get. 30, 40 degrees of flexion, 30, 40 degrees of extension. Megan, do you recommend an ophthalmologist or go straight to a neuro-ophthalmologist? I think an ophthalmologist will be very helpful in looking at the big things, right? Whether it's a retinal detachment, or are there problems in the back of the eye, or is it related to some issue with the lens? Neuro-ophthalmologist is going to be all the nervous system stuff. And so a regular ophthalmologist, for what we're trying to accomplish, trying to rule out the big stuff that can cause blurry vision, would be a good idea. Sure, John. Ulysses, have you treated sternoclavicular joint before it isn't related to CCI? Yeah, Ulysses, we treat, maybe 1 in 5 of our CCI patients get SC joint treated, or the SC ligaments treated, because they're frequently loose in CCI patients. And you might ask, why would they be loose? Well, they can be loose because there's some injury there, or because there's constant pulling of the sternocleidomastoid, which attaches there. But we treat those quite a bit. Barbara, how do you know if you have SI joint instability? Does the PICL help with issues further down the back, or do you have to see what's left after CCI gets fixed? Yeah, Barbara, a lot of that's history and exam. So for example, let's see. It was early this week or late last week. It's kind of blended together right now. But sometime in the last week or so, we had a patient come in whose history was pretty clear for an SI joint problem. What they told us was, you treated my CCI through PICL, got a lot better. But I do notice that when my SI joint is out, then this gets much worse. Now, obviously, that was an invitation for us to say, okay, we've got to start stabilizing this person's SI joint, which is the floor of the house, or the concrete pad in which the house is built. And if that is uneven, it's going to throw all the walls and roof off. So we're going to have to go and treat that. So it's usually things like that where patients will often tell you that they notice that there's a distinct change in what's going on up here, when their SI joint is out. And so that's something for you to kind of, as a patient, to start looking for. Linda, I have straightening reversal of the normal cervical lordosis and grade 1 rectolisthesis, C4 and C5, facial head, oral cavity numbness, arm numbness bilateral. Yeah, so Linda, if there's a question I can answer for you, please write that in those comments down there. Jennifer, can CCI trigger a seizure? Haven't seen that as much. We have seen certain CCI patients, pretty rare, but certain CCI patients who lose consciousness, and sometimes getting there to losing consciousness can cause a little bit of seizure-like activity, not necessarily a seizure. But as far as causing a seizure, we haven't seen that at this point. Bethany, does CCI cause alterations to fine motor skills, like picking up things with your hands and losing sensation, touch, or difficulty in grasping an object? You know, it can. That can also be related to issues in the lower cervical spine, causing pressure on spinal nerves that go to the hands, or even carpal tunnel, for example. Somewhere along that nerve pathway, there can be a direct issue, or because of the lack of proprioception, that can happen from the upper neck. Ulysses, do levoscoliosis, thoracolumbar get worse over time at a young age? So scoliosis is a little bit like a Jenga tower. You know, you have that game Jenga where you sort of pull things out. And if you notice, once the little Jenga tower gets a little bit off kilter, it's much more likely to collapse. And that's the nature of gravity with things that are asymmetrical, like scoliosis. So if you've got a little bit of scoliosis, it's more likely to turn into moderate scoliosis. And if you got moderate scoliosis, it's more likely to turn into severe scoliosis. So gravity plus a side bend in the spine is not kind. Or gravity is not kind to a side bend. Submit advanced by JT. Does someone whose CCI was caused by a car accident 6 months ago and is still able to work a desk job have a good chance of getting good results from a PICL procedure? Yes, I would say that that's a good category to be in. Stacy, you're freaking me out if so many people have notable imaging but no symptoms. Those of us with tons of symptoms are at a loss for finding the cause and resolution, unless you're saying it's the multitude of injuries that cause the symptoms. Again, just realize that, and it's an important discussion to have with patients, and one I have had hundreds of times, and that is that just because we see something on your imaging doesn't mean it's causing your symptoms. And in fact, the fine art of what we do in medicine is trying to say, is that thing I'm seeing on the MRI causing this physical exam finding and causing this set of symptoms? And it's all a big puzzle with the puzzle pieces having to match to be able to say, yes, all of this makes sense. And now I'm going to treat this thing. But the idea of false positive imaging findings is huge. I mean, it's a huge problem in medicine where we see these MRIs that show a disc bulge here, but there's no symptoms. So that's why we're so careful and cautious in looking at all of this imaging. And one of the things I try not to do is to rely on radiologists that overread, because it's easy to overread, right? You can just see this, I see that, I see this. But it all has to have clinical correlation. And there's a lot of things on imaging that we know are meaningless, meaning they're not causing symptoms. Ben, have you ever heard of PRI physical therapy and their course on visual integration and how vision affects the body? I haven't heard of that particular physical therapy outfit, but any course you can do that'll integrate the eyes and the neck and the inner ear, I think is a net positive. So there's another system out there where they put you in a chair and they kind of turn you this way and that way, and you are trying to follow a target with a laser pointer. And that's another attempt at trying to integrate the inner ear, the eyes, and neck movement. And reintegrating those things can be very, very helpful. Sure, Linda, Carla is your contact, and I put that her email address up there in the comments. Lissy, is there any way I could upload my MRIs or x-rays instead of sending you in the mail? Yeah, Lissy, we always recommend that you upload your imaging and not send it in the mail. So if you contact Carla, she'll give you a Dropbox link with a little video explaining how to use that. But you just copy and paste all the stuff on the CD or DVD, and you just drop it in that file, and it'll upload to the file, and then we'll download it on our end. So we'd much rather that than sending any CDs or DVDs in the mail. A, it's quicker. B, you get to keep your CD or DVD. We don't have to be in a situation where you have it or we have it and you need it. And at the same time, we can tell what you've put in there and what you haven't put in there, etc. Megan, do you think nystagmus is related more to COR or ganglion? My nystagmus and memory lapses improved as my neck gained strength. I only have it with far upper glance now, where I can tell my neck is still weak. Thank you for these videos and blogs. You've already saved my life and sanity. Well, thank you, Megan. So I think it's more related to the COR for what you're describing, because it's that COR that helps to coordinate eye tracking and binocular vision. And so that's probably the issue. Now, realize that when you look up, you can put pressure on some of those joints. So in particular, let's say the C2-3 joint, which is directly linked into the COR. So that could be as simple as getting, let's say, a PRP injection in the C2-3 joint if it doesn't go away, to normalize that input coming in from that joint. Because when you're looking up, you're putting pressure on that joint. If that joint's not happy already, then the information coming into the eyes gets worse. So that's one thing to think about. Linda, sorry, just wondering what could help. My spine surgeon does not think I'm a surgical candidate at this time, but signs and symptoms are increasing, and I find it very disturbing. Oh, let me come up here to what you had said before. I have straightening reversal of the normal cervical lordosis and grade 1 retrolisthesis, C4 and C5, facial head or all cavity numbness. So the big question, I think, would be, is there craniocervical instability? If there's not, then you'd want to treat that C4 and C5 retrolisthesis. Now, that's treating the anterior longitudinal ligament. That's something to consider getting done. Now, that's a pretty specific treatment and it's pretty specific injection that's highly technical. So that requires both ultrasound and x-ray guidance. And it can be very, very helpful when you have that problem. And again, it's ALL or anterior longitudinal ligament. Now, the only downside is that there's a lot to miss in the front of the neck. So we've got to miss the phrenic nerve that controls your breathing. We've got to miss the internal carotid artery that supplies blood to your brain. We've got to miss, and the list goes on of all the things we've got to stay away from to do that safely. So it's definitely a higher level procedure, but in the patients that need it, we've seen some amazing changes in them. There was one gal that was very, very active. She was a big surfer. She ended up getting in a situation where she got turned upside down, head went into the sand, head went back. She had a very clear anterior longitudinal ligament injury, single treatment, 90% better. But it had to be identified as causing the problem. She had seen lots of specialists. They had no answers for her because her MRI didn't look that bad. Ulysses, their evidence show that muscle spasms pull the spine out of alignment too, which affect ligaments and tendons. Muscle spasms can certainly pull the spine out of alignment. Sure, yeah. Okay, guys, so 148. So we're getting a little bit towards the end. If anyone has any other questions, happy to answer those, whether it's about today's topic or any other topic that you need answers on. I'm happy to answer those things. So any other questions out there? In the meantime, I'll start sort of wrapping up the concepts that we've discussed. So the first thing we've discussed is that your eyes and your neck are linked. And we talked about two different ways in which they're linked through the upper neck. One would be the cervical ocular reflex, or the COR, which is where the proprioceptors or position sensors in your upper neck link directly into controlling eye movement. And that's double checked against the vestibular input coming in from your inner ear, or the VOR. The second concept we discussed was that there are ganglia, or sympathetic ganglia, in the far anterior neck in front of C1, C2 that can get irritated and actually lead to a blown or dilated pupil, which can affect your ability to see things clearly because there's too much light coming in. Talked about those two things today. Just got another couple questions here. Floyd B, have you had patients with dizziness and vision problems because of military neck and some minor disc bulges? Not necessarily. So let's talk a little bit about that. So military neck would be a really straight neck, and we should have that normal curve. Now, what happens when we've got a really straight neck with a loss of cervical lordosis, as we call it? Lordosis just means curvature. So what can happen there is that the upper neck ligaments, these ligaments that we talk about a lot, the transverse ligament, the alar ligament, those ligaments do get more stressed. Now, maybe that's what's going on, or maybe it's just related to upper neck issues. But dizziness, if it's related to the neck, is usually related to the upper neck. So the minor disc bulges may not have anything to do with anything. And there may be problems in the upper neck causing the dizziness that have yet to be evaluated or identified. But the first thing to try certainly is to see, perhaps, if this sounds like a good fit, a CBP chiropractor. That's idealspine.com is where those guys are located, who can try to help with the military neck and see if those symptoms change. Obviously, if not, then you can get evaluated for CCI or upper neck problems that may need to be treated through injection. Patient of Dr. Schwartz, maybe Dr. Schultz in our clinic. I'm not sure. I had a PRP for CCI and was given a cervical fusion C4C7 in 2013 that I didn't need. I didn't notice at the time, but I had dropped right shoulder, which dislodged my scapular, and over time has affected my rib cage and tilted my hip. It all started in 2009 when I was seeing a personal trainer who had me lifting weights. Lightheadedness started at first, then neck pain. Then by 2013, I could barely walk, had bad neurologic symptoms, and felt like. So Sherry, happy to help there. I didn't see a conclusion. Maybe it got cut off. So maybe if you can tell me what your question is, that would be wonderful. Faction, retrolisthesis and lower cervical causes more numbness issues rather than other neurologic symptoms. Yes. So good point. If there is a retrolisthesis, and again, let's make sure everyone understands what that word means. Retrolisthesis is when one vertebra goes backwards on the other. Now, an anterolisthesis is the opposite. One goes forward on the other. So any kind of instability, anterolisthesis or retrolisthesis, in the lower cervical spine, you're generally going to see either more pain in the upper back area, lower neck, or numbness and tingling in the hands. Isn't SC joint related to shoulder instability with muscles and CCI too? Well, certainly it's a form of shoulder instability. The SC joint is here, so it's this part of the clavicle or collarbone, and the other part of the clavicle is way over here. So there's an AC joint and an SC joint, and both of these have to be tight because this is a strut. The clavicle is a strut that supports the shoulder. So if there's laxity to either end of this clavicle, at the SC joint in here or the AC joint out here, you can certainly have shoulder instability, yes. Sure. Happy to help, Floyd. Jennifer, I started feeling lightheaded as often happens, but it went beyond that to a strong feeling of fear, tingling in the back of the arms and stomach, and sense of deja vu. I never lost consciousness. Yeah, so the strong sense of fear could be that vagal nerve irritation that we've discussed before, or a block happening there. It could be activation of this sympathetic chain, either one. And as far as tingling in the back of the arms and stomach and a sense of deja vu, certainly the stomach vagus nerve and the sense of deja vu is something I have heard patients talk about. It may be related to what's happened in the eyes, meaning you're recalling a memory because of the eye movement that otherwise wouldn't be recalled. That's my only sense of why that could occur. Yeah, Sherry, it got cut off. So there may be a limit in the app you're using on the amount that you can write in the comment. So if there is a question, okay, I see you just put it in there. I'll try to get to that. Like, Lissy, by the way, I can upload more x-rays to, great. Jennifer, I kept walking, Googled it, came up as temporal lobe seizure. Yeah, so that's another thing to certainly consider. It's called also called an absence seizure, and a temporal lobe seizure can present the same way. Just realize that it doesn't have to be a temporal lobe seizure. So you may want to see a neurologist, obviously, to rule that out. And if they're saying, no, we don't see any evidence of why you would have temporal lobe seizures, or if the testing comes up negative, then it could be related to what's happening in the neck, because we have heard CCI patients say that before. Thatchet, how is a drop shoulder treated as a condition caused by something? Yeah, it all depends on what we're talking about. Usually what patients mean is one shoulder's up and one shoulder's down. So this can be this way for lots of different reasons. One would be that this side upper trap is pulling too much. Another could be that the whole rib cage is off to one side. So either one. And obviously treating it all depends on what its cause is. Sherry, I'm asking if an undiagnosed bad shoulder injury instability can cause CCI eventually due to shoulders not being level, not being able to support the neck and the head. I had difficulty walking for 3 years before having the fusion. Neurologic symptoms became too much. Yeah, Sherry, it's possible. We certainly see patients with scoliosis or side bend that seem to have CCI-like symptoms because the dens is getting pushed to one side in the atlas. Now, having said that, a lower cervical fusion also overloads the upper cervical spine. So we have a bunch of patients like that right now who, because of the fusion, they're getting what's called adjacent segment disease above and below. And the above for a fusion that extensive is going to be the upper cervical spine, C2-3, C1-2. Hence, they've got CCI-like symptoms, but really what's happening is they're getting overload of the upper cervical spine from the fusion, or what's called adjacent segment disease. So it's a CCI-like syndrome. It looks a lot like CCI. There may not be a lot of instability in the high upper cervical spine, but they're getting CCI symptoms because the upper cervical spine is where the forces are going when they turn their neck because of the fusion. Happy to help. Sherry, nerve tests were negative, so damage didn't cause it. Gotcha. Stacy, when we come to you for PICL and other damage, your office is able to help us find qualified correct PT where we live. Yep. Yeah, we usually use IPA physical therapists if we're going for physical therapy. So if you just look that up online, IPA physical therapy, like the beer, IPA, you can go ahead and find those providers. They're listed online. They've got a national list. Okay, guys, so we're coming up on the hour, and I'm going to start closing this down. I want to thank everyone for watching today. Again, we talked about how the upper neck and the eyes are linked, and I want to thank everyone for their wonderful questions. There's no bad question at You've Got the Power. The goal is to make sure that everyone understands what's going on, gets their questions answered, learns a little bit while we're doing it. And because in my direct clinical experience, patients that know more tend to do better. And they tend to make better decisions about their health care. They tend to get better quicker because they can navigate this crazy system we've put together called the American healthcare system. So thanks so much. Fatchin, I see you've got a question there. Just email me directly on that, or make sure Carol puts it in for next week's Facebook Live. So Stacy, happy to help. And you all have a wonderful weekend. I'll be here on Monday. I think on Monday, not 100% sure. We'll see what I get to this weekend. But I think I'm going to do the relationship between scoliosis and CCI-like symptoms or upper cervical symptoms, because that's one that's been coming up. And I may also do this link between upper cervical fusion and CCI-like symptoms from ASD this coming up Friday. So we'll see how that goes. So thank you so much. Have a great day. Have a great weekend. I'll see you back on Monday.